So our next speaker for this session is Cassia Chevillon. Cassia is a CNS eligible member of our team. She's a registered nurse who works with educational resources on making sure that the cardiothoracic transplant nurses are always up to par with what is needed to take care of the cardiothoracic transplant and the mechanical assist device patient. So I think you'll find her session very interesting because of our mechanical assist device program and the number of patients that we have started to implant HeartMate and total artificial hearts with. So since, if I recall correctly, since November of 2011 when we approved the program for destination therapy to date, we have close to 28 patients that have been implanted with those devices. So many of them go home. They go home on batteries, they go home on home equipment, and they may show up at your at the emergency department or any of the floors in either UCSD or any of the adjacent hospitals. So we felt that it's equally important for Cassia to be here and to talk to us about mechanical assist devices. Cassia, the floor is all yours.
All right, good afternoon, everyone. I know you just had lunch, so I'll try to be lively and keep you stimulated. Sometimes it's hard to come back in the afternoon. And it's also going to be challenging for me to stay behind the podium, but since we're being filmed, I'm going to try to stay back here. So, and if you guys have any questions, just let me know. You can raise your hand anytime. I'm happy to answer any of your questions. So, as Alex said, and thank you to Alex and Diane for inviting me to be here today. So I'm going to be talking about one of the VADs that we have here at UCSD called the HeartMate 2. So these are the objectives. I'm not going to really read over these, but it's basically just to introduce you guys to the HeartMate and give you some information that hopefully will help you in your nursing career here. So what is the HeartMate 2? So basically what it is it's a left-sided ventricular assist device. So what it does is it can provide an increased cardiac output for those patients that have heart failure. So we really only put the HeartMate 2 in chronic heart failure patients. It's not a treatment for acute heart failure. And it only treats the left side of the heart. So if a patient has heart failure on both sides of the heart, we can put an LVAD in the HeartMate and then try to recover the right heart with another VAD. And if they're really bad, we can put in what's called a total artificial heart. So that's another VAD that we use here at UCSD. But the HeartMate 2 is one that is really the only VAD that you guys could potentially see down here at the Hillcrest campus. So that's kind of why I'm talking about it. So basically what it does is just bypasses the left ventricle. If you can see in this picture, the bottom of the left ventricle, they basically just punch out a hole in the bottom of the left ventricle, and then they connect the pump there, and then it goes through that kind of silver section in the middle, has a pump inside that is constantly spinning at a very high speed. And it pulls the blood out of the left ventricle, puts it through that pump, and then shoots it up into the aorta and then out into the body. So it's basically just a bypass of the left ventricle. So who do we put these patients in? As I said, it's really only the treatment for chronic heart failure patients. So these patients are usually class 4 heart failure, or which is the worst, basically. So we know that these patients will not recover. They have non-recoverable heart failure. Their left ventricle is failed, and it's not going to get any better. So this is a treatment option for them. Their other treatment option is a heart transplant. So the HeartMate 2 can be put in as what's called destination therapy, meaning we can put the HeartMate in, and then they can just live with it for the rest of their lives. They can go home, and then they just live with the pump until they die of something else. Or we can put the HeartMate in and allow for a greater time period so that they can be on the heart transplant list longer, and then we will transplant them and give them a new heart. But as you probably know, sometimes it takes a long time to get a heart transplant, so this is what we call a bridge to transplant. So we use those terms a lot. We talk about if the HeartMate patient's a destination therapy patient or if they're bridge to transplant. So here at UCSD, like I said, these are only implanted up at the cardiovascular center. We have a number of cardiovascular surgeons that put them in. And then once the pump is put in, then the patient is kind of managed by a couple different teams, and that is the cardiothoracic surgeons and then the cardiologists, specifically the heart failure team, are the ones that manage it when they're inpatient. And then when they go outpatient, they still see cardiologists and they come to clinic often, so we watch them pretty closely on an outpatient basis. And then we also have 2 VAD coordinators here at UCSD that are on call. They're both nurses, and they share the call schedule with the other transplant coordinators. So they're really linked in with the lung transplant and the heart transplant program. So there's always resources available to you that are on call 24/7. So for you guys, if we're putting these in at at the La Jolla campus, then you probably want to know when you would ever see these patients. But like I said, they can go home with this pump, and that means that they could potentially come here, like if they go to the emergency room here. You can see them out walking around at the mall, or basically anywhere that you go they could be, except for in a swimming pool. So Dr. Adler, one of our heart failure doctors, always tells the story that he moved here from Oregon, and the first day that he was here, he went up to the Del Mar Fair, and he was waiting in line to get a snack, and it was at like one of those ridiculous places that serves like fried butter or whatever. And there was a guy like protesting the fried butter stand or whatever at the Del Mar Fairgrounds, and Dr. Adler went up to him and was like, "Why do you feel so strongly that people don't eat this way?" And he like opened his vest and had a HeartMate. So you might see these patients anywhere that you go. But here in the nursing setting, they could come through the ED here at Hillcrest, or they might come to an outpatient clinic. So these patients have other healthcare needs just like any other person, so they could show up in any clinic. We had one patient a couple months ago that we thought was going to get outpatient dialysis, and they were going to get it here at Hillcrest. He ended up not needing it, so the dialysis units could see this, so any outpatient clinic really could see a HeartMate patient. So if you work in an outpatient setting, you really don't have to know much about the HeartMate, just kind of some basic knowledge, because as long as the patient is awake and alert, he is going to take care of his pump himself, and he probably honestly will not want you to touch it because he knows it best. And so you really don't have to know much if you're in the outpatient setting, so I'm just going to teach you some real basic things and some emergency measures. And then on the inpatient setting, like I said, these patients can only be cared for on the inpatient setting up at the cardiovascular center. So there are some circumstances where they might be admitted here at Hillcrest. Not too long ago, we had a HeartMate patient that spilled hot chocolate in his lap, so he had to be treated in the burn unit. So he came down here in the burn unit, and then we brought one of our HeartMate 2 nurses down here to care for him. So you might see that, but otherwise, if you get in report or whatever, or hear that you're admitting a HeartMate 2 patient, your job is to just call the on-call coordinator, and then the coordinator will figure out if either A, they'll move the patient up to the cardiovascular center, or B, they'll move a nurse that's competent down to help you care for them here. So, and how you call the coordinator, you can just dial the operator and ask them to page the on-call transplant coordinator, or you can look them up in web paging too. This is a picture of what the patient would actually look like if you were to see him in person. If you look in this picture, the part that's kind of lighter, it's kind of hard to tell, but the actual pump part that I showed you in the other picture is the part that's inside. What does that pointer work? Planer. Okay, awesome. Okay, so this top section is the part that's actually inside the patient. So you can see it comes out of the left ventricle, goes through that little pump, and then up into the aorta. And then, so that's the actual pump itself, okay? But the pump can't work by itself. It needs a brain to tell it what to do, okay? So this part, this drive line, comes out from the pump into this thing, which is what I'm passing around. And this is the brain. We call it a controller, but it's really the brain of the pump. It tells the pump how fast to move and all of those things, okay? And then that controller, or the brain, can't work unless it has energy. So it's connected to batteries. So I pass the batteries around as well. It can be on battery power, or it can be on wall power. But in the outpatient clinic setting, you'll always see it on battery power. And then in inpatient, we'll plug them into the wall. And then we always have 2 sources of power, so if one source of power fails, then they have a backup. So what's important to know is that if this controller becomes unconnected from the power, the pump will stop. So you always have to be connected to at least one source of power. There's no backup battery in the brain. Okay, so again, like I said, HeartMate patients are super, super familiar with their pump. They live with it at home, and so they'll be able to take care of everything when they're in the hospital as long as they're awake and alert. So how's it back? There's a picture of Dick Cheney. He had a HeartMate. I don't know if you guys knew that. He got a transplant, so he doesn't have it anymore, but he's a HeartMate 2 patient, and there he's showing his batteries, telling the world how that works. So like I said, it can be battery powered or connected to the wall. If you're connected to both batteries, you can get about 8 to 10. I know some patients say they can get up to 12 hours of battery life. And for those of you who have the battery, there's a little button on the side. If you click it, or if you press on the button, it will light up and let you know how much battery you have left. And then once you have low battery, it will also give you a low tone alarm to let the patient know, hey, you need to connect to some source of power. And when they're home, there's all sorts of creative power sources. Like I know there's one that they can plug into the car charger so that they can travel. If they want to take a road trip, they're not bound by an 8-hour road trip. They can take longer because they have the battery charger. So again, just stressing to never disconnect more than one power source at a time. And for that, we tell the patient to only ever let one person touch things at the same time, because we don't want there to accidentally be 2 people messing with it and then accidentally disconnect both power sources. So I kind of already alluded to this, but if you look on the side of the battery there, oops. If you look on the side of the battery there, if you press that button, it will light up and let you know how much time you've got left. Okay. So this picture up in the corner is what the inside of the pump looks like. So it's a little spherical rotor, and it spins. We usually set it at about like 1,400 rotations per minute. So it's moving very, very, very quickly. So quickly that a lot of these patients don't need any anticoagulation. Some of them go home on just a baby aspirin and that's it, because the blood is able to move so fast. And what's interesting about this pump, and was really what made the HeartMate 2 so exceptional in the world of VADs, is that it is a non-pulsatile pump, meaning that that little spinny thing in there is spinning constantly. It doesn't push out blood at the same way that our heart does, right? With every beat of your heart, it pushes blood out, but this is just a continuous rotor. So what's weird about that is that most HeartMate 2 patients do not have a pulse, because they have no left ventricle squeezing the blood out. So for you all, that's really important to know. If you walk up to your patient, you feel for the pulse, and you're like, what is going on? Why does this patient not have a pulse? Now you know. Doesn't mean they don't have blood flow. It's just not coming out at a pulse with the beat of the left ventricle. Okay, so what that means is that the only way that we can check blood pressures on these patients is to do it with a Doppler. Okay, so some of them will have a faint pulse, and what that means is that even after we put the pump in, the patient's left ventricle does have some function. So just because we put the pump in, it doesn't mean that all of a sudden their heart's going to completely stop and just let the pump take over. If it still has some contractility, it will still pump. It's just that it's not giving the patient enough cardiac output. So it is possible to have a HeartMate and have a faint pulse, but more often than not, you can't feel a pulse. So you have to take your blood pressure with a Doppler. So the way that you do that is first you're just going to extend the patient's arm and see if you can feel a pulse. If you feel a pulse, you can take a regular blood pressure. But if you can't feel the pulse, you're going to take a Doppler, put a whole bunch of goo there in their brachial, and then you just put the Doppler on there and listen for the swishing noise. So again, I think you'd anticipate for the swish to be like a shh, shh. But again, remember, that's only if you have a left ventricle. So if you don't, it's a continuous swish. So it'll sound different than if you just have the Doppler on your skin. You won't hear any swish, and then once you find that artery, you'll hear the swishing noise, okay? And then you have to go way back to your early nursing days, or for some of you, maybe even before you were a nurse, and use a manual blood pressure cuff. You can't use the one on the wall. And you're gonna manually pump them up until that sound stops. And then you slowly deflate, and when you hear that swish sound again, that is their MAP. So again, this is a hard concept to grasp, but these patients don't have a diastole and a systole. You know, we all have diastole where we fill up, and then systole we push the blood out. But these patients have a continuous flow, so there's no systolic and diastolic. It's just the mean pressure. So it's one number that you're going to document, and you document in the map. So remember, a goal map is usually over 65. That's what we consider normal, okay? Any questions on that? Okay. Okay, so another really important thing with these patients is the Driveline Care. So the new generation of VADs that are not approved yet, but that we're hoping are coming down the pike in the future, there's no driveline. The patient's VAD is completely contained within itself, and when they lie down in their beds at night, there's a charger underneath their mattress that charges the VAD, so then they can live the day with no battery charging. Because really the only reason that these patients have to use batteries is because the pump goes from outside to inside. So new generation, we're working on that. Because the unfortunate part is that VAD patients, if they die, they usually don't die from from something with their heart. They usually die of driveline infections. So that driveline is coming from inside to out. It's pretty small. It's a little bit bigger around than a Foley catheter, but not too much bigger. And if the patient's really good about it and protects it well, then you shouldn't have any issues. But you know, it can get snagged. Like I know there was a patient on the East Coast somewhere that got out of his car and like shut the VAD in the car door and pulled the lead. So if you pull the lead, you can cause a skin irritation and lesion, and the driveline can get infected. So it's really important that we keep the driveline clean and secure. So most patients have several different devices in place to make sure that the driveline doesn't get pulled. And this is an example of one of them. It kind of looks like one of those abdominal belts, but it has a special slot for the driveline to come out. So if you ever have to do a dressing change on a VAD patient, you can essentially just clean it with chlorhexidine. Don't put any goo on it like Vaseline or anything. Just clean it with chlorhexidine, and then you can put some sterile 4x4s and paper tape, and that'll work. Okay, so if you guys you're not really going to have to take care of the complex VAD patient, but we want you to know just a few safety things. So if you were to ever encounter one of these patients in your setting, you'd know what to do. So the most important thing for the patient to know and for you to know is that the patient always needs to have extra batteries with them, so that if the batteries that they're on run out, they have another power source. So we ask these patients to always travel with 2 batteries, and then to have 2 extra batteries with them at all times. So if you admit a patient in the ED and they do not have their extra batteries, you want to ask their family to go back and get some. We have all of the extra equipment that we need here in the Hillcrest ED. We also have it in the La Jolla ED and in the ICU at La Jolla. But you always just want to reinforce to the family and the patient themselves that they need to have the extra equipment with them. And then we also ask them to always have an extra controller. So this thing, the actual controller, we want them to have an extra one too. In case the one that they have on them fails, they can switch it out to another one, okay? So we always have them carry those as well. And then also, and you guys can see I don't know who has the pump right now, but we also always want you to check to make sure that the lead is locked. So the lead that comes out from the patient's pump to the brain is connected through this little hole in the side of the controller. And if you press down on that silver tab, the lead can come out, and then we're in some serious trouble. So you want to make sure that the lead is always in place, and that this black piece is over that silver piece that you pull down, so that it's virtually impossible for the lead to pull out of the brain. So that's something that you always want to check if you ever see a HeartMate patient, that the lead is locked, so that they don't have the risk of coming disconnected. Okay? And then this just kind of goes through the panel on the side. For your purposes, I feel like you don't really need to know everything that's on the panel. It's good to know, oh, I keep on doing that, the battery, so you can tell how much battery is coming into the pump. And then this one, the red heart alarm, this is the alarm that goes off when something is seriously wrong, okay? So it's going to give you a really loud, annoying, continuous tone alarm, and it is telling you, like, look, I am not pumping right now. Either something is wrong with my brain, or I do not have enough energy to supply my brain. So So if that were to happen, the first thing you'd want to do is to call. If the patient is okay and awake, then let them deal with it, because they'll know how to deal with it better than you will. But if the patient is not awake, or if they, are like, oh, I don't feel good, and sit down, you want to call a code blue, because the code blue team here at Hillcrest is trained in the HeartMate. So that's the first thing you want to do. And then the second thing you want to do is try to assess, is their driveline kinked, or do they have enough battery power? It's most likely a battery power issue. So you want to go to the backup batteries and then put the new batteries on. So if you look on that one that's coming around, all of the controllers have 2 battery sources, like I said, if I can get this off, one black and one white, and they clip into the battery clips. So the patients will always have a battery clip with them, and that battery that I'm passing around just slides into this battery clip. I'm not passing these around because if you accidentally plug this into the machine, you're going to make it alarm. So you put the battery in this little box, and then there's a little half moon inside that you just match up, and you just squeeze on there and twist. Okay, so if you needed to change batteries, there's 2 ways you can do it. The way that I just showed you, to take this off and screw a new one on, or on the side of the battery clip, there's a little button on the side. You can just press that down, and the old battery will fall out, and you can just put a new battery in. Okay, so that's the easiest way. So if you hear that high red alarm, hopefully the patient can take care of it. But if they can't, first thing would be make sure their lead is not kinked, and then second thing would be is to replace their power source. So just switch out the batteries, and hopefully that will solve it. And then call a code blue. Okay, I think I already talked about all of this. So speaking of code blue, you can do everything that you normally would do for any patient, except we do not want you to do chest compressions. Because again, your left ventricle isn't working. For you to compress the left ventricle wouldn't do anything, and in fact it would probably dislodge the pump. So we don't want you to do chest compressions, but you can do everything else. If you need to defibrillate, you can defibrillate these patients. Think volume. The pump is going to run at a continuous speed no matter how much volume the patient has on board. So if they're dry, your pump is going to be working in overtime and it won't be happy. So be thinking volume. If you're having issues and alarming, it's most likely a volume issue. So that will be one of the first things that the code team will do, is give the patient volume. And like I said, the code teams at both here and the Hillcrest campus are trained in this VAD. Okay? So, available resources. This is probably the most important page of this entire PowerPoint, and that's just who you guys can call to get help, because we don't expect you to be experts now in the HeartMate in my 15 minutes that you've heard so far. So we want to make sure that you know that there's always a VAD coordinator on call 24/7, and these VAD coordinators know each patient by name because they work with them all the time, they see them in clinic, they know them very well. So if you call the VAD coordinator and let them know who it is, they'll know who you're talking about. Sometimes the heart and lung transplant coordinators cover for the VAD coordinators, but they're still trained in the VAD and can help you as well. Yeah, same group. So Dr. Adler is the primary cardiologist that works with the HeartMate. He's one of our heart failure physicians that I mentioned, and then Dr. Copeland is the main CT surgeon that does these. We have Dr. Pretorius and Dr. Medani are 2 other surgeons that put them in as well. And they're available 24/7, so if you need to get in touch with them, you can always call them. There's also a helpline if something is going on, like let's say that the patient's telling you that it's alarming, but the patient doesn't know why, you don't know why, you can always call the 1-800 number as well. They're available 24/7. There's an MCP. I can tell you that the MCP pretty much says call the coordinator so that we can get the patient transferred up to La Jolla as fast as we can. But there is an MCP available, and then there's also the critical care, like more unit-specific standards. So you can find that if you go to WebRef. On the top, like maybe third on the left-hand side of WebRef, there's a tab called Critical Care. Inside there are all the critical care policies, and there's a policy on the HeartMate as well, and it includes pictures and everything. So if you want to learn more, that's a good spot to go. And then there's also a lot of information. Thoratech is the company that makes the HeartMate 2, and they have a ton of stuff available online. They have videos that you can watch and online tutorials, a lot of stuff. So if you're more interested, you can go to their website. And then this PowerPoint is on LMS. So if you log on to LMS and you in the search box You can search LVAD or HeartMate 2. This PowerPoint will pop up, so if you want to look at it again. Oh, good. Good. Okay, so I'm going to quiz you now and see what you have learned. So I normally ask people to put their cell phones away during presentations, but I'm actually going to ask you to take your cell phones out now. And I'm going to walk you through this so you don't have to raise your hand. This can be totally anonymous. Your answers can be totally anonymous. So what you're going to do, if you pull your phone out, I'm going to ask you to text this phone number, 37607. So I know it's a short phone number, but it actually works. So if you go into your text box and then in your to part, you know, where you have to put in the person you're going to send it to, you just type in this number as if it were someone's phone number. And then in your message, you type in the answer. So the question is, who would you contact with a question regarding your patient's VAD in a non-emergent situation? Okay? So if you say code team, then you're going to text 605127 to this number. All right? And so forth, depending on how you're going to answer. Is anyone having issues with their cell phones? Yeah, and sometimes in this room, the cell phone reception isn't so hot. Okay, so I got 14 people answering so far, and all of you are right. So I'm glad that you got that one right, because this is a really important one, right? We want to know that you know who to call. So this is correct. You do want to call the VAD coordinator if you have any issues with the VAD, as long as it's non-emergent. And then if it were emergent, you would want to call a code blue. Okay, 22 of you. You're all getting it right. This is great. Okay, next question. If you should ever have a chance, if you should ever have to change the power source, only disconnect one power source at a time because, oh, this isn't giving you the whole answer. I don't know if I remember the answer. The first one is there is limited power when both are disconnected at the same time. The second one is you may lose important data if you connect them both at the same time. And then the third one is the patient's pump will stop if you disconnect both at the same time. So this one, I'll tell you, this one person got that one wrong. So don't answer by looking at what's up there. Okay, good, that's better. Okay, so the correct one for this one is that the pump will stop if you disconnect both power sources. So that's really important to know. Don't do that. Okay, good. So 83 of you are on track. 83%. Doesn't have it to do with data. Okay, next question. Uh-oh, I'm missing, I don't know what's going on that the full question's not showing up, but I'll read them for you guys. So the question is, the HeartMate 2 pump is a non-pulsatile and continuously flowing. Therefore, many patients will not have a palpable pulse. If this is the case, how would you take an accurate blood pressure? So the first one is you have to put in an A-line. The second one is if they don't have a palpable pulse, something, something, something. That's not the right answer. And then the third one is you have to do it with a manual blood pressure cuff and a Doppler. So good. So the third one is the correct answer. So you guys are answering correctly. Perfect. Okay, if a patient arrives with only one backup power source to a procedure, for example, they're connected to battery power, but they don't have any extra batteries with them, what would you do? So the first one is it's not a problem because they are connected to 2 batteries already. The second one is borrow extra equipment from another patient. And then the third one is immediately obtain backup equipment by contacting the VAD coordinators and asking the patient to go home to get their extra, or the family to get the extra stuff. Good. So that's the correct answer. Don't borrow from another patient. Okay, I think this is the last one. So in an emergency, like a code situation, what steps would you take? So the first one is begin chest compressions and follow ACLS. The second is follow ACLS but do not perform chest compressions. And the last one is nothing, as the pump is there, so if the heart fails, that's the end of the road. Okay, good. So we're getting the right answer. So you would follow ACLS just like you normally do, or not ACLS actually, ART is what we do here. You'd follow that so you can defibrillate the patient, do all the things you would normally do, but you do not want to deliver compressions. So, and that's it. Anybody have any questions?